Welcome to Take Charge with HELPcare. I'm Lee Aase, your host, along with Dan Hinmon, my co-host, and we're delighted today to have Dr. Steve Borene with us. Dr. Steve is an anesthesiologist in Wisconsin with some Minnesota roots. I met Dr. Steve Borene at the Free Market Medical Association conference in Oklahoma City. And he's in a little different branch of direct care called direct specialty care as an anesthesiologist. A HELPcare clinic is a direct primary care. Dr. Steve does direct specialty care. And I thought it'd be really great for us to have him come with us from a couple perspectives. First, he is in that direct specialty care space, but then also he is the chapter co-leader of the Free Market Medical Association for Wisconsin. And much as it pains me to say, in Wisconsin, they're quite a ways further down the road in the whole direct care movement than we are in Minnesota. So I thought it'd be great for us to both learn from that Wisconsin experience and also from his perspective in the direct specialty care.
Yeah, excited to have Dr. Borene on the call today with us, or on the podcast with us today. And so, Dr. Borene, maybe we start with you giving us some background. Like, where'd you go to school? How did you decide what kind of medicine to practice, and et cetera?
That's great. Thanks. Thank you very much, gentlemen. It's always a delight to go ahead and get to share what we're doing, because we really think everybody should be doing it this way. So we want to get the word out. I am an anesthesiologist, as Lee mentioned. My Minnesota roots. I grew up south of the Twin Cities. Went to, after some time in the Marine Corps after high school, found my way to college in Minneapolis at Augsburg College. And when I made the decision to go to medical school, I chose the University of Minnesota, right? You know, that's where all my family was, all my roots were. My wife and I, who also grew up in the same hometown as I did, expected that we would spend our whole careers in Minnesota. That's where our roots were. After training, I found that there were other advantages to practicing outside of Minnesota. And so we made the decision at that point 25 years ago to leave. Finished my training at the University of Iowa and worked in private practice there for just a couple years. And then we made the move to Wisconsin 18 years ago and been practicing here as an anesthesiologist ever since. I started in private practice, which had a lot of autonomy, a lot of advantages. Small town in Iowa. It didn't have some of the comforts of a larger town and some of the opportunities. So for family reasons, we moved away, but the practice was great. The traditional type practice that people followed 25, 50, 100 years ago in many ways. I could go ahead and make decisions with patients. I could tell them exactly what it was going to cost to have things done. There was transparency between us and the independent surgery group and the independent hospital. And I thought that's how practice worked everywhere. When we moved to what we felt would be a better place for our kids, for what we were looking for, I took an employed position as an anesthesiologist, and I found that everything changed for me professionally. I was now at the beck and call of another organization when I had a patient that needed care but couldn't afford it. I couldn't work out a deal with them. I couldn't give them a discount. I couldn't come up with an arrangement. A great example is when I was in private practice, I had a patient who was a laborer and he needed a knee scope, a meniscectomy. On his knee. He was able to work, but he had pain and was limiting him, and he didn't have any money. So we started our discussion on surgery day with the statement, "I can't pay for this, doc." And I noticed he had a pack of cigarettes in his pocket, and I said, "Hey, if you quit smoking, I'll give you free anesthetic." Just seemed like it was going to be a good connection. It was going to fit into my schedule. He was already there. And you know, I knew a little bit about him. I knew which crew he had worked on. So I had a little connection. He didn't know me at all. And he said, "Wow, that, you know, really nothing." I said, "Give me $25 a month until it's paid off." It was going to be about $2,000 for my portion. I said, "And you should talk to the surgeon." And went and talked to the surgeon. I said, "Hey, he can't pay." He's like, "Yeah, I already worked out a deal. I should have mentioned it to you." And the surgeon ended up working a deal he was going to charge him $50 a month. And I don't know what his total fee was and everything, but I threw in the extra point that if he quit smoking, I'd cancel out the rest of the bet. Just seemed like the thing to do, and one of my partners had done that before. So he said, how do we do that? I said, you show me 2 negative nicotine tests a week apart, and I'll cancel out whatever's left of your bill. Until then, keep paying me the $25 a month. And so we went ahead, did the surgery. Everything went well. He received his care. He recovered, went back to work. And about 2 months later, he came by my house with 20 of 5 and a piece of paper. And I looked at him. I said, hey, I was mowing the lawn. He came by, and I said, what's going on? He said, well, I owe you. I didn't make the first payment, but I wanted to show you this test. And he had 2 negative nicotine tests that were a week apart. I said, that's great. I said, you quit smoking? He said, yeah, that's wonderful. He said, are we all square? I said, you bet. I don't have any of the paperwork. I'll call in the office on Monday. He said, you sure? You really going to do that? And I said, absolutely. We shook hands on it. Why not? And I said, but what took you so long? It's been a couple of months. And he said, well, it was a failure the first time. He said, I haven't had a cigarette, but when I went for the first time to get the test, I tested positive because my wife was still smoking. And I said, oh, so, she's smoking outside now, or how's that work? He said, no, she quit smoking too. He's like, yeah, at the time they were saving over $1,500 a month in cigarette costs. And so it was easy. He said, it seems kind of a shame that I'm not going to pay you, but thanks for that. And that worked great. Well, about 2 weeks later, I got a big thank you from the foreman from Jamie's crew, who said, Jamie is my best team member. He's back at work. Because of what you did, he was just going to take unemployment until he started feeling better. But as a result of what you did, by giving him that discount on his care, he was back at work within just a few days, and it's made a difference for my team. What can we do for you? And we didn't shovel the driveway that winter. We had brush cleared, all things that I never asked for. My family thought it was pretty neat that I'm hanging out with worker guys, right? It was a real benefit. It wasn't quite the chicken and the eggs and being paid in that way, but it was in many ways more valuable and made a difference in his life. And so that's how I could do things when I was in my own practice. As soon as I took an employed position in a health system, when I had a similar patient and I thought I'm going to show them something, I'm going to do a real clever way, they said, no, he needs to talk to the patient rep. Patient rep and they'll figure out a payment plan. They'll do something on their own. They're experts at this. And the patient rep came in, they spent 20 minutes talking, and next thing I saw the patient that had the same situation. Next time I saw him, he's walking out the door in his street clothes. He said, I'm not having surgery today. I know how this is going to go. They're going to send me a bill, and I'm not going to be able to pay it. And they're going to send me to collections, and I'll just take my unemployment. And so that was kind of my wake up to what's going on in the health system. After a decade and a half, I was frustrated. I felt like I'm not talking to administrators. I'm not getting some of these ideas across. So I went and I got a business degree in healthcare delivery science at Tuck Business at Dartmouth. And I thought, now I'll be able to connect with these administrators. And what I learned in that program more than anything else is that the system's working exactly as it's designed. Right? They're doing exactly the things that they intended. And physicians everywhere are noticing this. They're getting more and more frustrated. That's where we hear about burnout, moral injury to physicians. And I found, as an example, I had a patient with an EKG that we were waiting on before having surgery. It was midweek. And I had talked to the patient. He was a healthy 52-year-old who ran a marathon on the Sunday before the procedure. He came in and I saw him. I approved him for the anesthetic for the procedure he was going to have. And I sat in the operating room waiting. At 7:15, when we were late for the OR, I asked the nurse why we aren't in the room. And she said, we're waiting on the EKG. I said, well, I didn't order it, and I'm the only physician that's going to see it, and I don't need it. We can go. And they wouldn't let the patient come back without getting the EKG unless I canceled it. I said, well, I better check. I'm not in the habit of canceling other physicians' orders. So I contacted that physician. He said, well, I needed to order it because he met criteria. I realized that he won't have any benefit from that, but I was required to do that. So I'm not going to cancel it. But if you want to cancel it, I understand. I said, okay, well, I'll cancel it for you. So I canceled it. And within the first hour of the case, I had 3 emails. One from the perioperative manager, who said these patients meet criteria for an EKG. They need to all get it. When you did that, you took away some of the work that these people were expecting to do, and that costs us money. Another one was from the primary care doc's manager who said, this doc is required to go ahead and order these. This could reflect negatively on him if he doesn't order that, because this is a way for us to go ahead and screen these patients before the procedure. And also I got an email from the cardiovascular, preoperative cardiovascular system. I can't remember what the title was exactly, that said the EKG tech and the cardiologist are both needing to be supported by this organization. And by you canceling the order, they had less work to do and less benefit there to the organization. So all these people had managers that were encouraging the additional cost to the patient for absolutely no benefit. And so that's just an example of the system that exists out there right now. And because of that, and because of what my partner, Josh Johnston, who's also an anesthesiologist, had seen, we had looked around and we thought we need to find another option.
Wow, nice explanation of what got you there. So how does specialty direct care actually work compared to primary direct care that we're more used to in our community?
Sure, a lot of it's the same, right? In fact, some of the procedures we do are just an extension of the primary care, especially with the colonoscopies, which are preventative. That should be considered primary care, and in some people's mind would be. It's just the procedures that support a primary care doc. But direct care, whether it be specialty or primary care, the key feature there is that it's direct, right? Everybody's either a buyer or seller of healthcare. I sell healthcare. That's what I do. I sell medicine as an anesthesiologist, as a physician. So do nurses, so do health systems, so do ambulatory centers, infusion centers, an MRI business. They're selling something from healthcare. And patients are buyers of healthcare, and more often, in fact, most of the time, it's employers are the payers, are the purchasers of healthcare. So what direct care does is connects those people, or it recognizes that those are the key components to a medical or health relationship. So connects buyers and sellers. There are middlemen, what do we call them, facilitators, that also play a role. The goal of direct care is to minimize the role of facilitators. Now, if there's a facilitator that brings buyers and sellers closer together or helps one or the other, then they're beneficial. And that's where brokers can be. That's where businesses can be, where maybe there's a group that serves as an aggregator of business, brings different health plans together. All those people serve a valuable function as long as they provide a service to either the buyer or seller. So in direct primary care, it's the difference, I suppose, would be the subscription model that's typically used in direct primary care. But that's just a change in the payment mechanism. It's you develop a relationship that makes the caregiver actually accountable. I put my name on our business, right? I can be found. Patients can track me down. I deliver a higher level of care than I would if I'm hiding in the middle of a system, just naturally. And that's the same for direct primary care docs. They put their name right, they hang their shingle out. People know who they are. They aren't anonymous hiding within a system. And so the direct care will go ahead and elevate the physician care and role in that care, and make it more accountable back to patients, right? That's the whole key here. There's no accountability in healthcare right now. Right now, there's a whole bunch of people in the middle that nobody knows about and can't tell what's happening. And so we remove that. So it's a direct relationship between a patient and their payer and the caregiver. For us, it doesn't really work to have a subscription, because although I can tell you how many people will likely have surgery 1 year to the next, I can tell you what percentage of covered lives are likely going to have a colonoscopy in a year. We can look at macro data to go ahead and determine how much somebody can save within a plan. That's still pretty dissatisfying to people when they can't actually claim it to an event. So we think of it more of episodes of care. Because life is an episode of care, right? You have a broken window at home. What do? You're either going to fix it or you're going to hire someone else. You look at that episode. So we look at surgery and infusions and GI procedures as episodes of care. And for us, it's all inclusive. GI procedure, we come back to colonoscopy often because 2.7% of people in every covered plan are gonna have one every year. And we go ahead and have a transparent bundled cost that includes the anesthesiologist, includes the gastroenterologist, includes the pathology fees, That's really been what sets us apart from everyone else. Polyps are included. That's been a punchline. We've gotten some laughs about that. But what isn't a laugh is how much it can change somebody's colonoscopy. A lot of people will be told your colonoscopy is free or it's included in your health plan. But then as soon as it goes from being a screening colonoscopy to a diagnostic colonoscopy because a polyp was found, it falls out of that free or included range. And because they can recode it, suddenly the $6,000 procedure costs $11,000. And oftentimes the employee is on the hook. We had a gentleman just a few weeks ago who was told he had a free colonoscopy. He went in, they did a whole bunch of work. He ended up with a $17,000 bill. And he was supposed to follow up in a year. And when we saw him for his follow-up, it had been 3 years because he had put off the following up. His wife kept telling him, you need to go in and get this taken care of. But he said, we haven't paid for the first one yet. I'm not going to go do that. When he came in for us, he ended up with the same procedure, and it was under $3,000. And the fact that we took a number of polyps, that there was took longer, extensive pathology findings, it didn't matter because we had already promised him a price. And that's what happens when you've got accountability in every relationship you do, just like any other business would do. I mean, you wouldn't buy a TV at Best Buy, not pay for it, and then 3 months later have them find out that you put it in your great room instead of your family room, and now they're going to charge you more for it, and it turns out you connected it to the internet. Well, that changes. Now it's a home entertainment system instead of just a TV. They're going to charge you more for that. We wouldn't stand for that. It's none of their business. You went in and you made a purchase. Well, in healthcare, we accept that all the time, and it's ridiculous.
Yeah, I think you talked about something that really resonates, I think, with a lot of people because they go in for that screening colonoscopy and they're told that it's going to be free. And then you find a single polyp and then it's recoded differently and it's, thousands of dollars more. And I think that's one of the things that we've seen is in some of these self-funded health plans where they put in some good incentives for the employees. They say, if you go to this place, we know that it's going to cost that much no matter what. And even if they find a polyp, there's going to be no charge to you because you just negotiated a fair price. And then it takes away the reluctance. I mean, that person that you were talking about that waited 2 years for a follow-up that he should have had, that's actually putting him at risk, isn't it?
That's very dangerous. Right. People are dying because of this. We have had in all of our patients that we've taken care of since last July for colonoscopies, we just had our first patient about a month ago that didn't have any polyps. And why is that? You think, okay, there should be about a 40% polyp rate, but we have a nearly 100% rate. Why is that? Well, that's because we do have a selection bias from the patients that are finding us. Because a lot of these patients are people who've been burned before, or they have heard of someone who's done that before. And a lot of these people have put off their care. We get people who were recommended, their recommendations would say when you're 45, you should come on in. We see them when they're 57. Well, they knew they were supposed to come in years ago, but they didn't because they know the risk. And that's a very real, it's important. We're not taking care of one of the key aspects of a person if we're ignoring the financial aspects. And I've talked to a number of physicians and people in healthcare over the years who said, well, we don't want to get into that. We want to keep that separate. Well, guess what? The insurance companies and the hospitals don't want to keep it separate. They want those funds. And how can you take care of someone if you're not taking care of their finances? That plays a role in every decision that we make around our home with our family. Go do this? Are we going to not do this? Can we go out to dinner tonight? Can we repair the car? These are all financial decisions. Healthcare is no different. It's a financial decision. And it's a shame because there are some really bad decisions that people make in the short term. They're willing to gamble. They shouldn't be gambling with some of these things. They don't want to, but they're put in a position where they run the risk of bankruptcy. And it's a very true and real thing. You're 6 times more likely to declare medical bankruptcy if you have a health plan. I mean, think about that, right? People get health care because they're worried about the tragedy. They're worried about the big accident or the big cancer diagnosis, yet they are more likely to go bankrupt if they have that coverage. because when they go beyond their regular coverage, when their deductible, sometimes it could just be the deductible is enough to knock some people into bankruptcy. But when all these additional costs come up and they go over what's been the maximum, they're on the hook. If they're paying cash, if they're in a direct pay arrangement, they're going to know what those costs are up front. There are going to be people that will work with them. Most of our procedures are done well below the cost of a deductible, for example. In fact, if a lot of our patients have insurance, and I would say probably most have insurance, but it's at least somewhere around half or more. Right on your profit share. So that's your plan because you value them.
One thing I wanted to add on that is, you talked about for somebody that might need to get a hysterectomy, that they might spend less just paying the entire amount out of pocket with you compared to submitting it through for insurance. We see something really analogous to that with direct primary care membership, is that if somebody has a $5,000 or $7,000 deductible, they can get a whole year's worth of membership with us for about a third of that, maybe a quarter of that. And then they actually get the care, because the problem that people have with the big deductibles is that even if they have a health savings account, they consider that their money. They know that there's tax advantages to it and everything. And they're just really reluctant to go pay the full prices for everything. Whereas if they can get a membership with us or with another direct primary care clinic, they're able to actually get the care that they're paying for. Now, it doesn't count against their deductible, and there's all that part of it. But for most people, if they're able to get most of the care they need and get timely care that heads off problems, then they probably aren't likely to need the rest of their insurance anyway, and they just have it as the safety net that it's supposed to be.
So, so Dr. Borene, from a practical view, how does a patient decide they can go to a direct specialty care provider? How do they even find you? How do they even know they have that option in their healthcare choices? So, you mentioned in our conversation so far colonoscopies and hysterectomies. What other kinds of cases might fit in your direct specialty care?
Just in closing, I'd just like to have you talk about, from a specialist position, from the as the provider, as the seller of care. What would you say to people who are like you were, frustrated in the regular healthcare system, about how difficult it is and what or whether they should, consider direct specialty care? Thanks for joining us, Dr. Steve. We're really glad for this conversation, and Dan, appreciate your participating as well. And we look forward to helping people better understand the direct care model, both in direct specialty care and direct primary care. Thanks for joining us. If you enjoyed this episode, be sure to leave a comment or a review, and to subscribe on Spotify, Apple Podcasts, or on YouTube. And also to share Take Charge with HELPcare with your friends and on your social media channels. At HELPcare, our passion is helping people take charge of their health and their health care, helping employers take charge of their health plan expenses, and helping physicians and other practitioners take charge of their healthcare careers. Learn more about the HELPcare Clinic difference at helpcare.health.